Greetings, and thank you very much for joining us on number 42 of our RedETSA webinars. We're pleased this morning to organize for the first time a joint webinar, including the Spanish network for the evaluation of technologies, RedETSA. So once again, thank you very much from our colleagues from the Spanish network. This is collaborative work, which we began last year. And we hope that with this webinar and some other activities, which we will announce in brief, to follow up on this very important coordination. So as I said, this is the 42nd webinar evaluating health technologies applied to digital technology. We're going to hear from Spain and Canada. I am Alexandre Lemgruber, and I am in charge of health technologies within PAHO, within the Innovation and Access to Medication Department. And I would now like to send greetings from our director, Judith Rios. This is a relatively new department, which was set up approximately a year ago. And at this time, I am the interim head of the Department on Access to Medications and Health Technologies. So welcome one and all, and thank you for your participation. But I would remind you that we have simultaneous interpretation. We have 2 channels for interpretation and a main audio channel. And what we will make available is the recording on our website. And we also have the PAHO channel where it will be available. So this morning, what we're going to do is hear from Canada and Spain on their experiences. And then I will present our speakers. But I did wish to point out that we have selected this topic today. And I will introduce Marcel in a minute. But we think that it is important to apply evaluation to digital technologies and digital health. And this is gaining strength more and more. And as we know, technology evaluation requires specific frameworks, having the different dominions for the technologies. There is a traditional areas, legal aspects, social aspects, ethical, organizational, among many others. And we know that in general, these methodological frameworks are useful in order to evaluate most of the different health technologies. However, on the other hand, we also note the need to develop frameworks that take into account the complexities and the specificities, so that we make sure that we have a more rigorous and comprehensive evaluation. Now, we hope that what we'll be able to do is present some of the available frameworks. And so we will share experience and see what dimensions are possible for evaluating digital health technology. And we will hear from Spain and Canada. And during the presentations and under Q&A, you will be able to pose your questions. Now I would like to introduce my colleague, Marcelo D'Agostino. He is head of the unit on information systems and digital health in the Department of Evidence and Intelligence in Action for Health. First of all, I would like to thank Marcelo for having accepted the invitation. and he will touch on the main lines of work of PAHO's work in digital health. Marcelo will certainly indicate what the priorities are for PAHO. And so there have been a number of requests so that our webinars also demonstrate how the evaluation takes place and how important it is for decision making when it is related to the technologies of digital health. So for this, I would like to invite Marcelo to offer opening words. And thank you for joining us. Thank you, Alexandre, and congratulations for having launched this initiative. For us, this work is fundamental. It is interprogrammatic work, because one of the points that we see within the unit that I am heading is the question of everything digital, which seems to be permeating all of our lines of work and all of the different areas of public health. So what we're trying to do is develop an interprogrammatic approach. We have the mandate from the director of the organization, Dr. Jarbas Barbosa Silva, has placed us at the highest level of priorities among his 5 pillars, defining his vision for this administration, and he's mentioned it also in his opening discourse and speech. Now, in all of the meetings that have taken place during this new administration and meetings with heads of states, presidents, ministers of health, the question of digital health always appears. Now, we have a number of areas of work, and something that we've been talking about with the Department on Innovation and Access to Medications and Health Technologies, and much has to do with regulation. And we also focus on AI. Now, we have 3 broad areas for our work. And the first goes to information systems for health, and we like to review the government, the management of data, infrastructure platforms, positioning of the health sector as a part of electronic governance. The other has to do with digital health specifically, made up of a number of elements. We also work on telehealth specifically, and we look at the primary level of care. We also have another area which has to do with artificial intelligence. We look at cybersecurity, and we also look at interoperability, cross-border interoperability, and the transfer among countries, and with digital certification. So we work hand in hand with the Inter-American Development Bank on this. And lastly, we have a broader area that we're beginning to launch. This will be in the second week in June, a program on digital literacy, so that we can join all of these other initiatives. And once again, thank you for having invited us to participate, because we believe that we need not only access to information and training, but we need to rethink the profile of those who are working in public health, so that among their skills and in their CVs, we see that digital health is a part of their ongoing education. And we don't want this to be put aside as an optional course that someone may or may not take. And lastly, to close, we also work interprogrammatically, because we think we need to join other areas, but we also promote network collaboration. and we have the reference network worldwide, but we also promote not only network areas, but multi-sectorial work. We cannot talk about digital transformation unless we include all of the entities in charge of electronic government, technological infrastructure, and telecommunications, involving also research institutions. And fundamental to all of this, and I'm sure you have experience, we need to see how we can position these debates and make sure that they are included in our different parliaments. And they are the ones who will move the instruments so that we have public policy defined. I don't want to go on much longer. We're all here very much awaiting to hear of the experiences from other countries, in this case, Canada and Spain. And once again, thank you very much, Alexandre and Judith as well. Thank you, Marcelo, for your words and also for sharing your priorities. And I would also like to congratulate you for the excellent work you are doing. And there are numerous opportunities for this interprogrammatic work. And this also brings in AI and a number of other lines of work involving regulations, and then there's match and learn and many different challenges. Thank you very much. So we're going to now continue, and we're going to see the Spanish network and see how they evaluate technologies. And we will give the floor to the Spanish team. And Rosa Maria is the director for evaluation of the Agency on Health Quality and Evaluation in Catalonia. And then I will ask Rosa Maria to also introduce her colleagues and her team. And they will share their experience, the experience of the Spanish network on this topic. And we will then present our next speaker. So, colleagues from the Spanish network, you have the floor. Thank you very much, Alexandre. You have introduced us. Now we're part of the networks, and in Catalonia there is another network, but there isn't a single agency in Spain evaluating technology. We work as a network with 8 different agencies, and we all use the same methodology for purposes of evaluation. Carolina, would you like to present? Yes, I will share my screen. I believe everyone can see the screen now. Wonderful. We'll move on to the next slide, but before explaining the technologies, what we've also wanted to do is provide a bit of the context of the health system in Spain. In Spain, we have legislation, we have universal health coverage, and this last week, a new bill was approved to broaden the coverage so that more will be able to benefit. And this means that different medical services are provided. We have the common benefit package, which is provided by the Ministry of Health. We can also broaden this area with providing with more services, and this is a complementary benefit package. And hospitals may have their own packages. and they would be in charge of providing all of the services that had been in the prior packages. And the different institutions that are involved in the evaluation, as Alexandre said, in the case of the Ministry of Health, it is for the common benefit package. And this is through networks and an annual plan with the participation of all of the autonomous communities in Catalonia's ACUS, and in the case of the hospitals, it's a bit more heterogeneous. And it's the different hospital units that are in charge of it. So after this brief introduction, I will give the floor to Carolina, who is in charge of evaluation in ACUAS. Carolina, go ahead.
Thank you very much, Rosa. I'm going to focus on this part of the presentation, and I'll be, well, excuse me, I'm going to go to English.
Digital health technology assessment in Spain. First of all, I will start saying how were we doing this evaluation up until now? Well, we were using a framework that is based on the EUNETA framework from the European Network of HTA agencies, and this framework considers 9 domains. 4 of these domains are considered core. These are the description of the health problem, the description of the technology, the safety, and the efficacy and effectiveness. And next to this, there are 5 implementation domains. These are more specific of the context of each country. These are the organizational, human and socio-cultural, ethical, economical, and legal and regulatory aspects. The limitation of this framework was that it does not explicitly address aspects that are very relevant for the digital health technologies. And you can think about interoperability, interpretability in the case of AI, or issues of data privacy, among others. That's why the Spanish Ministry of Health commissioned ACUAS to develop a new framework specific for the assessment of digital health technologies. We developed this framework together with the other Spanish HTA agency and key stakeholders from the digital health ecosystem. It is available since December 2023, both in English and in Spanish. The framework contains 2 main sections. Section A, that details the domains, dimensions, and subdimensions that are necessary for the evaluation of digital health technologies, and Section B, that describes the standards of evidence that need to be provided for these technologies in order to prove their value in the healthcare systems. And these 2 sections are preceded by a section that describes and classifies the technologies according to their purpose of use. Starting with this first chapter, here you see what technologies are under the scope of the framework. And the framework can be used to evaluate mobile health technologies. You can think of health apps, non-face-to-face healthcare services, standalone software, such as algorithms of artificial intelligence, and software used to analyze data from medical devices, such as scanners, sensors, or monitors. Instead, the framework is not intended to evaluate digital health technologies that facilitate data collection in research studies, software in a medical device, or digital health technologies designed for providing training to healthcare professionals. In the framework, you will also find a table like the one showed in the slide to classify the technologies. This is based on the evidence standard framework from the English agency NICE. And the table consists on 3 levels, tier A, B, and C, from lower to higher level of risk. In tier A, we find the technologies that are intended to save costs or release staff time, and they don't have a direct impact on the health of the patient. In tier B, we find the technologies that help citizens or patients to manage their own health and wellness. And in tier C, you find technologies that inform clinical management, drive clinical management, or are used to diagnose or treat specific conditions. In tier C, we find the technologies of a higher level, and those that are most likely to be regulated medical devices. And as such, they need to be classified also according to the corresponding regulation. So going to section A. Here I show the same image that I showed before with the 9 domains from the EUNETA framework, but also the new domains that are included in the new framework. They are the technical aspects, the content, the environmental aspects, and the post-implementation monitoring. Within each of the 13 domains, we also detail the dimensions that are included in each of them. For instance, for safety, we now look at clinical safety and at technical safety. And for the economical aspects, we look at costs, use of resources, and the full economic evaluations. Here, for instance, for the technical aspects, we look at the usability. For ethical aspects, we look at equity and fairness, which is very relevant for artificial intelligence. And for human and sociocultural aspects, we focus on user experience, accessibility, and some other dimensions. How will you find these domains shown in the document? You will not see the hexagons that you have seen in the previous slide, but you will find a figure like the one in this slide with the domains at the top in dark blue. And then hanging from some of them, you see the dimensions, and some dimensions include even more specific aspects, and we call them subdimensions. In light blue, you also see what dimensions are more specific for artificial intelligence. What else do you find in the document? You find guiding tables. This is an example of such a guiding table for the safety domain. You see the description that explains what does this domain mean, then the associated dimensions and subdimensions. In this case, for safety, we have the clinical safety and the technical safety. And then we have indicative questions that guide you to understand exactly what you need to evaluate in this domain. Then possible sources of information to complete this assessment of this domain. Then the standard of evidence that is associated with the domain. And finally, some observations. Moving on to section B about the evidence standards. There are in the framework 21 different standards organized in 5 blocks related to the different stages of the life cycle of the technology. We have standard 1 to 9, relates to the design factors, standards 9 to 13 about describing value, standards 14 to 16 about demonstrating performance, 17 to 18 about delivering value, and 19 to 21 related to deployment considerations. In the framework, you will find a detailed description of each standard, recommendations for response, and their relationship with the domains, dimensions, and subdimensions that I showed before. To give an example of what is an evidence standard in the framework. Here you see, for instance, standard 14, which was in the block 3 about demonstrating performance. It is a standard that asks you to provide evidence that the digital health technology is effective to support its claimed benefits. And here you see, for instance, that it asks that to provide evidence that shows that using this technology has an impact on the clinical management of relevant conditions in a setting relevant to the national healthcare system. And it also gives an orientation of what kind of studies you should perform or you should look for, depending on the intended purpose of the technology. And with this, I give the word to my colleague Joan so that he can show you a real use case of the application of our framework.
Bien, muchas gracias, Carolina.
Thank you, Carolina. Now, as my colleague was saying, I'm going to explain a real case of application of this methodological framework that we've carried out, developed over the last couple of years, starting in last November. Thank you. Now, for background, we're going to give you an example of the application of this. This is the use of mobile apps for rheumatoid arthritis. What are the mobile applications with these traits that are commercially available in Play Store, Apple Store, and in health hubs? First, to assess or evaluate the available scientific evidence on health apps for smartphones and that enable the detection of rheumatoid arthritis and flare-ups, and to look into the degree of implementation of health apps within the context of SNS, the different countries of the EU. Now, to answer these questions, different methodologies were brought to bear. On the one hand, we did a mapping review to ascertain what the different applications of a commercially available would be, a scoping review, and then a national survey and international survey to see to what degree these tools are actually being used. Now, methodological framework. The first step was to identify or verify whether the mobile apps that we have to assess are within the scope of this methodological framework. And if they were, we move on to the next stage, which is to verify what classification these technologies fall into, what categories. What level they fall under. In the next phase, what we did was based on the characteristics of the tools, we had to assess mobile apps in this case to identify rheumatoid arthritis. We had to consider certain information from the patients. What domains and dimensions were germane to identify the value that would be corresponding within the Spanish healthcare system. Now, according to the objectives that we've already addressed, what we did is to map out what the domains and dimensions are that my colleague just talked about, and to identify them and to say which were the most important or germane ones for the case in hand. These different dimensions that you see on the screen, these were the ones that we considered that for the types of affections we were looking at. Once this exercise is carried out, then we move on to the next slide. What we did here, the last phase, was to look at standards of evidence were applied during the evolution of these technologies. Regarding the results of the report through the mapping exercise or mapping review, what we did was to identify 460 different apps, 49 of which identified through scientific literature that we gathered through our review. And of that number, some were from the Play Store or the Apple Store in the different countries described in the previously described methodological framework, and also what the inclusion factors were that were also in the report and that were assessed at a deeper degree, more accurate or precise degree. Now, here, what you can see in the scoping review are the results of this effort. Now, we recovered 3,868 different references through a systematic search of databases carried out by our expert search system. We looked into research literature as well, according to the different criteria, parameters that we established for this. And lastly, only 13 articles were included in the report and were the subject of the assessment. Now, evidence reported by this very meticulous process, this was initially all mapped out according to evidence criteria, as you can see here now. Namely, what we did was to make a list of the research studies that we identified, and we tried to correlate what evidence they provided according to the dimensions that were determined to be germane for this evaluation. Now, as you can see, there is a large number that don't provide evidence, and this was also identified in the report. Now, on the next slide, beyond these evidence, the matrix of evidence, matrices, for each one of these studies, they were looked at from the standpoint of the different domains, and all of the descriptions, such as you can see here on the right-hand side of the slide or the screen, and we identified then what type of evidence had been found based on the tool used and how many studies actually addressed this dimension or domain. Here you can observe the results found during this survey. Now, this was sent out nationally, internationally. We only obtained responses internally or domestically. 96 different respondents answered, different healthcare professionals, and only 11% said that they had used such tools in their areas. Now, I should point out that only one of the tools that they reported as one being used met all of the inclusion criteria established in the initial phase, protocol phase of the report. The other ones were the ones only for health professionals and didn't really refer to the monitoring of rheumatoid arthritis flare-ups felt by patients. So what are our conclusions? Now, the search engines of the different repositories of apps are not very accurate, very low levels of accuracy, not enabling us to really identify this type of tool. It was very hard to find the techno-scientific information about the apps identified in the app stores, or some apps were found, but they weren't of particular interest for the report at hand. Now, in addition to the tools that we identified that did meet the inclusion criteria and that were the subject of our analysis, we've had a hard time, again, finding the scientific clinical documents that actually described their characteristics and what drove their development and their application. Now, only 3 of the 21 apps had any European Union marking. Now, as far as the scoping review, the evidence we found was quite limited. As I said, a small number of articles with different designs and quality ranging from low to moderate actually aligned with what we were looking for. There was much heterogeneity in the outcomes of variables analyzed and types of variables and measurement instruments. In addition, something else we wanted to stress is that thanks to this methodological framework, we were able to identify some aspects which, through other types of frameworks used to assess, traditional frameworks to assess digital technologies, there were those that said, based on The fact is that the apps that were found didn't actually assist in large measure for patients to have access to the healthcare services they were seeking. So what are we doing in relation to the AI assessment? And I'd like to talk a little bit about what we are doing right now in the EU. Regarding artificial intelligence, we are collaborating currently, taking part in a health and AI program with the Health Department of Catalonia, which seeks to create a conducive environment for the development of AI that would assist in providing healthcare to the population. We are updating our forms, templates, and we're coming up with specific templates for gathering technical information according to the different sectors or industries. We are also collaborating with new organizations to be more pragmatic in how we assess technical aspects of AI with different stakeholders of the healthcare system of Catalonia. Now, over the next few months,
also, as Carolina commented, we're having some other ways of evaluating AI, and we hope to do this more in depth. Now, what are we doing at the EU level? We are joining in a project, a 4-year project, which is being financed by Horizon Health 2023. And the idea here is to have a framework at the European level, which is adapted to different needs and different stages of maturity of the different apps for digital health that require evaluation, and that it also bring in the different technologies of this very large umbrella under the name of digital health. Now, where can one find all of this information? Well, you can scan this QR code, or you may go directly to these links at the bottom of the page, either through our own website or the Spanish network, Aquas or RedETSA. So to conclude, I would simply like to thank you and thank the organizers as well for having invited us to share our experience. And unfortunately, the mic went off for a second. Thank you very much, Juan. I also wanted to thank Carolina and Jose Maria for their excellent presentations. Please send in your questions, because after the next presentation, we can have our Q&A session. So we will now move on to our next speaker. And so she will now speak in English, and I will speak in English.
And we'd like to invite Lydia Brahimi from the INES. INES, as you may know, colleagues, is a member of us, RedETSA, for a long time. And it's HTA agency in Quebec, Canada. So Lilia Brahimi is a public health graduate with a background in bioethics, health information systems, and scientific communication. Lily is part of a growing team of Horizon scanning professionals in health technology, innovation, and health systems transformation at INES. So thank you so much, Lilia, for accepting this invitation, for being with us today. I would like to share with you and all colleagues connected that now we at this moment, we have more than 300 participants in this webinar. So great news. And I would like to take also the opportunity to thank my team, and especially Marlene Holman, who is always responsible for organizing our webinar sessions among several other activities related to RedETSA. Thank you, Marlene, and all the other members of our team. Lilia, you have the floor.
Thank you very much, Alexander. Thank you. Hi, everyone. It's a pleasure to present this to you today and following the wonderful presentation we just had. So I just want to preface this by saying that perhaps my presentation will take us a step back into what might be considered when a team is trying to build from the ground up, really, a framework and to be in more of the exploratory phases. So I'll start by giving you a word maybe on INES, whose mission is to promote clinical excellence and the efficient use of resources in the health and social services sector. So it's an agency that is affiliated with the universal public healthcare system that we have in Quebec and in Canada more generally. And in the Quebec context, we've had a digital transformation that has been really shaping the healthcare sector lately, leading to more and more questions on the proper way to integrate digital health technologies into the care pathways of users, and more specifically when it comes into HTA agency in terms of evaluation and reimbursement of these technologies. So I'll be taking you through a presentation that will first look quickly at the methodology that we took to delve into this topic, a few digital health evaluation frameworks that we've identified, some findings from the patient and public consultations, as well as those framework, and a conclusion and brief takeaways. So just to mention that this work has been undertaken between the years 2022 and 2023. So the frameworks that have been identified obviously do not include more recent ones, and it's such a fast-growing environment that there might have been frameworks that have been elaborated since, including the one that we just saw. So this project, this report that we published in 2023 was originally a mandate from the Ministry of Health that was interested actually in how digital health solutions can be evaluated in Canada and around the world. How are they currently being assessed by other agencies? How are they being integrated? There was also an interest in the obstacles and facilitators to implementing digital solutions in the care and services pathway. So we were also concerned about what might be some challenges and some elements that we can put forward to help with those challenges. So I'll be mostly focusing on the frameworks, and I'll speak briefly about the challenges if that is of interest to some of you. We undertook a scoping review in two parts, evaluating the scientific and gray literature and consulting with patients and publics on the findings of these frameworks. So I'll actually speak quickly about the INES framework that we use for our regular activities in terms of health technology assessment, also in terms of interventions and other modes of care. So the approach is based on a sort of global appreciation of the value of a health technology or an intervention, and its intention of the framework is to really look at the technology in a holistic way. And so it is comprised of 5 dimensions of evaluation. The first of which is the clinical one, and to say that an intervention should ameliorate or improve the health and well-being of the population that it is going to be administered to. The populational aspect seeks to look at the well-being of the entire population to which the service or the technology will be rendered available. The economic dimension is obviously interested in the optimization of resource utilization and the responsible management within the healthcare system for long-term use. And the organizational framework aspect is interested in the way that the technology will be integrated in the current way that the system is organized. So does it fit well? Does it really strengthen the system? And finally, the sociocultural dimension really is concerned with the more global way that the technology inserts itself in the system, and whether it facilitates the evolution of the healthcare system towards the common good. So these 5 dimensions are really a sort of framework for us to really think about everything both in terms of social care, but also in this context in digital health. So using this framework, we really wanted to see what has been done elsewhere, and how does that fit with the way that INES conceives of its appreciation for value in healthcare. So we've identified 5 frameworks that have been published. There were more, but we really wanted to have a diversity of frameworks that come from the regulatory sphere, from other HTA agencies, some of them being from a mix of both. We also identified a hybrid platform. So the NORDEC, for example, is it is a framework that actually is to be used in multiple countries in the Nordic countries, and a digital health agency. So this variety of different agencies that publish the frameworks allowed us to really also analyze the differences between them and look at what could be the optimal way to proceed for Quebec. So these 5 frameworks came from Germany, Belgium, the UK, Switzerland, and as I mentioned, those 5 Nordic countries. I'll describe them quickly here. So they really vary in terms of both their approach and the methods that they take to evaluate digital health, as well as the digital health technologies that are covered. So not all the frameworks actually include all the same kind of technologies. So starting with the evidence standard framework, which you've now heard of about. It is the British NICE agency, which is an HTA agency that has published these standards that are quite evolutive. They've changed since the first edition. They've now include applications for AI, as well as other kind of technologies. They provide a very comprehensive guide for developers and evaluators as well in both designing and assessing the digital health technology. So it's a very collaborative effort that really wanted to put forward both guidelines for those developing the technologies and those assessing it down the line. The technologies included in it have kind of shaped, I would say, the way that other agencies sees them. So they've created a classification based on use and risk that colleagues have presented before. So it's a very useful way to classify and to be able to associate certain standards based on the level of risk, based on the projected use of the technology. The second framework that we've located is the validation pyramid de validation in Belgium, which is a collaborative effort between INAMI, the regulatory agency, the statutory health insurance, and mHealth Belgique. So there were multiple stakeholders involved in creating this 3-tier pyramid that also is a formulary that comes with a formulary for developers to submit a request to the regulatory agency for reimbursement once the technology has been marked as a medical device. So this particular process is reserved for what would in the first case be considered only the tier C, so only the ones that are regulated as medical devices. So we already see here a difference between different countries, whether they will be willing to assess a broader scope of technologies or more limited to health applications that are considered medical devices. The third framework, and also one of the most, I dare say, interesting one, is the German DIGA. So it is a fast-track process to reimbursement, published again by the regulatory agency under the latest law for digitization of the healthcare system. So there were multiple legal frameworks around this as well, and the application that the manufacturer or the developer has to submit to be included in a DIGA inventory. So it is a catalog sorts of applications that have been assessed and approved to be eligible for reimbursement by insurance. And importantly, it is applications that have to have a professional or personal use upon prescription. So already we see a different modality here, that the app has to be prescribed for it to be reimbursed. And so the assessment also takes a fast track process with a period of intermediate reimbursement, and then upon gathering more data from real world evidence, the app might be eligible for permanent reimbursement. So it's a process that has also been quite one of a kind, and very forward in its application. We've also identified a catalogue de critères, which is a catalog of criteria that the Swiss agency eHealth Suisse has published. It is more of an academic work, so it is itself a collection of criteria that either personal users, developers, professionals, providers can use to assess and critically assess the use of certain apps. So it is geared towards all sorts of applications. It does not come with any reimbursement process. It is really a sort of personal guide for users, and it serves obviously as a beginning for more appreciation and assessments of applications. The last framework is a Nordic. It is constructed by ORCA, which is a British agency that specializes in digital health technology. So we have more of a private actor coming in with the Nordic Council, a public grouping of multiple Nordic countries to create a voluntary accreditation for applications to be included in a repository of apps that have been approved. So we see here a more voluntary approach as opposed to other regulatory agencies that might actually be more mandatory. So this diversity of frameworks have allowed us to not only to see differences between them and different approaches that could be potentially undertaken in Quebec to inform our own decision-making, but also delve a bit more in detail in the frameworks and look at the criteria that each of them use. And so I'll go through a few of these criteria, but quite briefly, mostly to look at the takeaways, because the entirety of the criteria are available for your consultation. But what's really interesting here is to compare and see what are the different questions or standards or elements that are included in the framework, and how can we organize them back into the 5 dimensions that you'll recognize here. This could eventually lead to, as a base, to identify potential gaps, and it is a useful exercise for any agency wanting to develop their own framework. So starting with the clinical aspect, that the ones that are raised by the framework mostly concern the evidence for clinical efficacy, description of risks associated with the technology, mostly clinical risks, as well as its impact on the user's quality of life. The organizational factors were geared more towards regulatory context, the technical aspects of digital health solutions as well, such as data security, interoperability, and systems operation. So we see really concerns that have to do with data protection and safety protocols to make sure that the technology integrates itself in the organizational context in a safe way. The economic aspects were mostly centered around the parameters of budgetary impact on the system and the cost effectiveness, obviously, of the app when it is possible. And so not all the frameworks were capable of putting forward the criteria of cost effectiveness, because they do not all come with the same expectations. The sociocultural aspects of digital solutions are a lot less present in the framework. So we identified quite major gaps there. But when they were present, they mostly mentioned user participation in the development, the conception of the app, and alignment with broader clinical guidelines that are in place. as well as its credibility with healthcare professionals and their potential adaptability with them. The last domain, the populational one, focused on more, I would say, epidemiological concerns. So number of patients projected to benefit, the description of the target population, what are the unmet needs that this digital health technology seeks to bridge, what are the gaps that it bridges, and what might be some impacts on health equity and inequalities. So these criteria allowed us to really kind of take a look at what has been done, but what the second part of the report and the project gave us a bit more meat around the bone. And so we were able to identify some major barriers and facilitators for implementing health technologies, digital health technologies, sorry. So this was these were the results of the literature. Some of the most major barriers related to equity of access, obviously, especially when it comes to vulnerable populations, either young children or older adults who are less able to use technology. The accessibility and security of personal and health data, most of this also related with a lack of understanding of where the data was going, who it belongs to when we're talking about, for example, a connected device. Who does the data belong to? How much ownership does the patient at the end of the day is able to get back? Especially in a context where a healthcare system might be fragmented, it's incredibly important that patients remain the owners of their own data. System interoperability, obviously, in Quebec, we struggle quite strongly with a lot of different health information systems throughout our different infrastructures and clinics and hospitals. So interoperability is a major key facilitator. Training and support, both of staff and patients, is very important. The workload for health professionals is a very important aspect because it is often overlooked when we look for technological solutions to sometimes not technological problems. So considering the workload that this might be either adding or helping the health professionals with. And lastly, the considerations for reimbursements. It is, I would say, at the core of these frameworks as to what the pathway for reimbursement might look like. Will it be conditional? Will it be permanent? Will it come with development of real-world data as the app is developed and put forward? So there are so many modalities of reimbursement that are possible, and this might create also issues for payers and insurers. So I'll conclude with some findings from our patient and public perspective consultation. So we were able to consult with a partner, 15 members of a patient participation group, and they really added even more insights into what we found, telling us that the impact of digital health technologies might have something of a consequence on the quality and the nature of the relationship between providers and patients by altering the way that patients and providers communicate and expect each other to behave. The importance of training for patients and providers to enable them to use the digital health technologies properly, to be really in control of the way they use it, and to properly access all the functionalities and take advantage of all the improvements that it might lead to the treatments, to the diagnosis, whatever the technology is used for. The access to healthcare data came back again and was really corroborated by our patients. The impact of privatization of a segment of the health and social care system was also of concern, given that most of the applications that are submitted for approval, for assessment, or for reimbursement come from private actors, and that there will undeniably be an impact on the way that the system is organized. And finally, a very interesting aspect related to the lack of attention that is currently being given on the environmental costs of digital health technologies, particularly on servers and the data that has to be hosted, but also on the actual material fabric of these technologies. So all these perspectives really brought to life everything that we found, and we are currently in the process of pursuing and continuing these findings. There's work that's being done on understanding better what might be the right option for a digital health technology framework in Quebec. And with this ongoing work, we hope that lessons and experiences from abroad also continue to help. So I'll conclude here, and I have linked to the full report if anyone is interested in finding it.
Thank you very much, Lilia. Excellent presentation. Thank you so much. So we are going to move. We have a few questions. Some of them came for the Q&A session. Some came from other ways. So I will start with a question. One question that I have. Take advantage of my role as moderator, and so we give a little bit more time for our participants to take their time to send us more questions. So we have 25 minutes for this Q&A. I think it's with plenty of time. So the first question is, I may be wrong, but you tell me. But I have the impression that HTA usually HTA is always a very multidisciplinary field, right? But I have the impression that when we talk about HTA for digital health, it could be also even more multidisciplinary. Many areas involved, stakeholders, different areas of the organization. For example, starting with our organization, with PAHO. So if we talk about assessing medicines or medical devices, so those are technologies that are handled in our own department here, the Innovation Access to Health Technology. But when we talk about digital health, there's another group in the organization, in another department that we just met, Marcelo, it's the head of the unit of digital health in another department. So I suppose it happens a lot in the country. So my question to our colleagues, Spanish colleagues, and also to Lilia, in your countries, could you let us know about this level of coordination? So how do you, which actors are important in, and I'm sure the regulatory authority, of course, but maybe other actors are important in this dialogue. And I'm sure there's, as you mentioned during the tour presentations, for us it's clear that lots of advances, but lots of challenges that has to be addressed. It's a very evolving field. And how do you manage this necessary coordination and articulation among several stakeholders in the specific case of digital health and HTA? Rosa Maria, go ahead.
No, I was going to say that I will give the floor to Carolina and Joan, and they will explain how these different stakeholders, when they presented the framework, I don't know if you saw that the different agencies and also different directorates of the Ministry of Health of Spain and also the regulatory agency, IAMS. But I give the floor to Joan to explain that, and then to Carolina, that she will explain our collaboration with Fundació TIC Salut and Social about the artificial intelligence program.
Excellent.
Bien, muchas gracias por pasarme la palabra, María.
Thank you for giving me the floor. So let me start by saying, as Alexandra was saying earlier, when we speak of digital health, the truth is many more stakeholders come into play in evaluating these types of technologies than the traditional health technologies. Now, from my standpoint, this is something that we see, or there are two main factors. One is the technology itself and the characteristics that it has, because you have to, it brings together huge amounts of data that changes and evolves over time, and then you have a dynamic interaction directly with the final or end users, who are, on many occasions, the patients themselves. This raises challenges in ethics as well. While developing the methodological framework in line with the different existing regulations, we contacted the regulatory agency in Spain to delineate what was being said in the framework from the existing regulation, looking into Spanish and the EU's regulations, and how that helped to define these different technologies. Now, as far as the different reports on health technologies and their integration, the clinical advisor, for example, sometimes they were healthcare providers, but each time, or professionals, but each time, or patients and providers, but also advisors with technical know-how were brought in, because they are the ones who are more deeply steeped in knowledge about the technical aspects of this type of tool. Now, Carolina could also address this. One of the things that the sociocultural aspect is something that comes into play here in this type of technology. Now, furthermore, as I was saying, something else we incorporated to lesser or greater degree were the patient, who sometimes have a very dynamic interaction with this type of application. Carolina, if you would like to delve a bit deeper into this. Thank you. Yes, I'll just complement and address the work that we're doing in the assessment of the tool and the use of artificial intelligence and the domain of the technical aspects. We did see it's very important for us to draw from clinical know-how and knowledge, as well as the technical and the health aspects. Both had to be looked at. And so we had to have that expertise built into our team, especially the ones knowledgeable about technology. That's why this collaboration was so important, which from which we reaped so many benefits. And so a technical advisor from Catalonia really helped us through the ICT technologies that were brought to bear. Now, when a new technology comes in that we have to evaluate, we focus, or they focus on helping us look at the whole technical aspect or domain, any type of built-in bias in the algorithms, how those algorithms were trained, ethics, the explainability, legal aspects, privacy, data privacy, and cybersecurity, that they are very important stakeholders that we have included in our evaluation processes. Thank you very much.
I would only add really that, as Carolina said, it's very important that stakeholders are involved in developing a framework that will eventually be used for the entire population. So at INES, we have the deliberative processes that seek to bring different clinical and patient participants around the table. Also, a lot of technical expertise is needed specifically in this field. And in this particular project, we were approached by the Center for Excellence in Patient Public Participation. So there are a lot of structures already in place, and the collaborations go both ways. So Ines is always seeking for participation, and we find also ourselves to be approached by different actors interested in having a voice in the future frameworks that will be put in place. It has to be a very collaborative effort.
So, thank you very much. Vou empezar aqui a ler algumas perguntas.
I'm going to read a couple of questions. I see questions in Q&A and chat. And so everyone connected, perhaps you could help me if I overlook anyone, fail to mention anyone. Some have given their names, some haven't. One that's anonymous asks, is it possible to apply the evaluation tool in such a way that it is directed toward or focused on a given particular technology information system that's under implementation? And anyone can please answer that. I can try. Now, the question has arisen here if whether an information system falls within the scope of our assessments or evaluation framework, given the characteristics of this information system. If we were to say that, yes, it does, well, there would not have any problem in applying the framework, even if it's still underway, its implementation is still underway, because we could start by looking at the legal aspects, the regulatory aspects, technical ones, the different types of evidence relative to efficacy or safety comes under the scope of our evaluation. A block of evidence, there might be a block of evidence that's not in a given early stage, let's say, that's not available, perhaps cost effectiveness or social aspect. That evidence needs to be looked at as it is generated, as we go along. I don't know if I answered that question. I think you answered it quite well. Thank you very much. Now, if there's a panelist who would like to complement, anyone who wants to ask a question or anyone who wants to chime in, please turn your camera on so we can see you as you speak. Now, someone is asking about the presentation, so let me just say that all the presentations are going to be made available on our webpage, so just answer that question. Now, there are a few other questions. Here's a question in English from Daniel Risato Lede.
Have you done any evaluations regarding open source softwares like DHIS2, Open EMR, Open MRS, etc., that could be useful for other decision makers, even though not fully applicable, as they should be customized for other environments? Who wants to take that? Lilia, go ahead.
Unfortunately, we haven't been able to assess these, and those actually fall under the they fall under the responsibility of the hospital or the establishment that is wanting to integrate them. So different responsibilities in terms of assessment also mean that not all of the technologies that will be incorporated, especially in terms of EMRs, will be the responsibility of the HTA agency. So this is another challenge when certain health technologies want to be integrated at the hospital level. They might not always go through the HTA agency. So it's a question that really raises an interesting challenge.
Excellent. Thank you very much, Lilia. We have another question for you, direct for you, and that's from Ofelia Nossetti. Ofelia is from the HTA agency in Uruguay, AETSU, and as the following. Está em espanhol, pero vou já tentar ser. It's in Spanish, but I will make the translation if now. So the question is the following. So can you please tell us a little bit about the? I think you mentioned already in your presentation, in your comments right now, but I will read anyways. How do you could describe a little bit more about the articulation with the civil society beyond the barriers that you already mentioned? For example, level percentage of participation / invitation, or if there is any other groups that are more engaged than others in the process.
Yes, I can speak to particularly the Center for Patient and Public Participation, which is a Quebec-wide group that engages patients in their care, and so they become both patients and also sometimes research participants, or they become in a way integrated in the improvement of the services. So this group of patients and public are particularly inclined to improve their care because they're directly affected by it. There might also be age and demographic differences on how likely certain groups might be to be involved. But the consultation and the involvement of civil society at large is also done through in very different ways. So there's currently a new EMR, a new patient portal that is being rolled out, and that comes with also the consultation of the public on its use. So there's a lot of different efforts to involve civil society, but it's a very imperfect science because you can never capture quite everyone at once. So opinions might vary depending on also external environments, the adoption of certain technologies over others. But generally, when the public is consulted, it is usually through partners and deliberation processes.
Excellent. Thank you. Thank you very much, Lilia. We'll try to see now next one. Let's see. Okay. Switch to Spanish again. Esta é a pergunta de Marco Quadros. E a pergunta é a seguinte, eu vou pedir então aos colegas, nesse caso de Rede Espanhola, pergunta objetivamente.
A question from Marco Quadros. Are technologies for high-cost diseases using the same methodology, or are they dealt with differently? Perhaps Rosa Maria will have more information to add to the answer, but for now, we're not differentiating high-cost disease and the use of different methodologies and digital health. There may be some differentiation when we evaluate traditional technologies, but not for now. Well, to add what Joan said, when we prioritize our work plan, the different networks could explain their tools. So when we use the common services, a request is made, and much has to do with the impact of the disease. And this is one of the criteria for prioritization. And it would be used for digital health as well as other technologies. Excellent. Thank you very much. We have a question here from Daniel Risato Lede. And the question is it possible to add Spanish and Canadian ETS reports on digital health to BRISA, B-R-I-S-A?
todos sabem que estão conectados, porque temos muitos invitados que não são de RedETSA, são de fora, são muito bem-vindos, bem-vindas.
Now, BRISA is our regional base of information on health evaluations. And we already have more than 3,000 reports. It was set up in 2017. So it's been in place for 7 years. Now, if we have time, perhaps our Spanish colleagues can comment further. But meanwhile, we are progressing in order to reach an agreement, which we hope to conclude soon. But we hope to have all of the reports from the different agencies that are a part of the Spanish network, as well as of BRISA. So we're very excited about this. And so we raised some of the challenges which have to do with compatibility. And we also have the reports from INES. Those are already included. Not all of them, but many of the reports are available with BRISA. Here we have a question from Oscar Rodolfo Banela, who is the director of the electronic department of the School of Engineering of the University of Córdoba in Argentina. The question is the following: in the framework presented, do you have design factors that must be followed in order to satisfy the standards? How are you planning in the future to evaluate the different digital health technologies? Well, Joan and Carolina did talk about the standards for evidence, but it's mostly to make sure that the developers generate the evidence. And then there are criteria to take it into account for an evaluation. If this is what it refers to when it comes to design. No, maybe it's our colleagues from Tixalub that need to answer, which is a collaborative side. Those are the ones that have more experience. This could be used in the framework to help the developer and to help in other areas. So this is something to be taken into account when we work collaboratively with other institutions. Any further comments? I'm not sure if I've answered the question. I would simply add that we do have guidelines and standards for the developers in order to make sure that they are satisfying the standards. But it is true that we don't have it all with a checklist to see that if each standard has been satisfied. Now, the foundation is a key element so that we can make these evaluations more precise. Very well. Any more questions? Otherwise, I will move on to the next question.
Next question is from my country, from Brazil. And the question came from Dr. Betty Salvador, the Federal University of São Paulo. And the question is the following. Could you please tell us what the speakers think about the importance of digital health curriculum guidelines in the health university curricula for academic training and professional qualification? Did you want to start?
With pleasure. This was both one of the findings from our consultation with patients and from the literature review that we undertook. We did find that insufficient training, both for professionals and for patients, but in the context of this question, since we're talking about providers and professionals, it's of utmost importance, and it does begin at the stage of formal education, so in the context of universities, and training was found to both empower doctors to make the right decisions in terms of care. It also makes them more knowledgeable and makes them better prepared to either prescribe or suggest the right health technology. It also makes them aware of their development and which areas, for example, in mental health or in assisting with treatment adherence or different uses, be it in symptoms management. So the different areas in which health technologies are being developed. It also, in turn, improving their training on the matter also makes them better able to support their assessment, because they will eventually be involved in the deliberation process for their assessment. So it makes them more knowledgeable down the line to identify potential issues in the clinical context that might not have been brought forward by other reviews or data without proper context. So the qualitative quality of their training really comes at different aspects, and it also helps with unintended consequences for the workload. So involving health professionals early on in their education, the concept of digital health technology development and assessment really helps them inform the design and bring forth, for example, issues that might come forward with their workload, or the way that the technology integrates with the rest of the pathway. They might be able to say, well, no, we cannot use this app at this moment because we're supposed to be interacting with the patient in this manner. So they can really it's a win-win for themselves and for the development of the technologies.
Thank you very much. I have so many questions right now, and we run out of time, but I would ask for if you could have 3 more questions, and then we close. I have to apologize for the colleagues that we could not answer the questions, but I will try to, if maybe we can send the question to the speakers. So 5 more minutes, and then we close. I have a very interesting question about, I would like to address the participation for several colleagues from our country offices, but one in particular is here in the Senate. I'm at Jean-Claude Felix from our PAHO country office in Haiti. And Jean-Claude Felix, and it's interesting question that I would like to, if your co-speakers, to reflect on, since of course Haiti, you know, is a low-income country or several challenges. And the question is the following: how can we assess the level of maturity, the maturity level of the health information system in a country as Haiti? Not an easy question, but go ahead if you can try. Someone?
Me gustaría responder, pero personalmente no tengo la respuesta para poder darla.
I would like to answer, but quite personally, I really don't have the answer in this case.
It's a very difficult
Lilia.
question, and the Quebec context might be different for all sorts of demographic, economic reasons, but really the maturity, assessing the maturity of the health information system that you have in place is key. And if it is not ready, it is simply not ready, in a sense that there might be other things that might simply be a priority over the development or the integration of a digital health technology. But having a benchmark is already quite good, and in Quebec, the efforts are towards standardizing healthcare systems that are otherwise extremely fragmented. So that's also a huge challenge in its own way. And so centralizing the knowledge and knowing which systems are used where is the first step. I would say that's beyond that. It's very context dependent, but having a benchmark of the current health systems information that are used is always helpful.
Excellent. Thank you. Thank you. Excellent.
To add something, I was just...
Of course, sure, go ahead.
It is really a difficult one, so I also don't have the answer, but I was thinking about aspects such as interoperability, cybersecurity, data privacy. It's the words that come to my mind when thinking about this kind of technology and maturity levels.
Thank you very much. So, as I said, there were several questions. I would try the two. I make two last one, and then you can decide which one you want to, if you want to respond to both of them, or you can choose. So we can wrap up in 3 minutes. So the questions are two questions. One is from Carlos Villa, and they said the question is if you can talk a little bit about thresholds for cost effectiveness for technology for digital health, for when you assess technology for digital health, if there is specific thresholds that you consider, or just apply the threshold that you usually apply for any. I mean, we know that some countries has explicit thresholds, some countries there's a more implicit threshold, but if there's any consideration on thresholds for specifically for digital health technologies. And the final one they would make is about is from Tarcísio Aquino. I said that once evidence show that using the digital health technologies impacts on clinical management of the relevant conditions, is there possibility of tele-rehabilitation? And there's any experience that you could describe the speakers on the, assessing technology for tele-rehabilitation?
Si quieren, puedo intentar responder la primera pregunta que has lanzado.
I can try to answer the first question. Now, we do not have a threshold which has been broadly accepted or which is being used, but we do have a threshold for any type of technology, which is around 30,000 euros. But for now, as far as I know, we're not working on changing this threshold when it comes to digital health technologies. Nevertheless, in reviewing the literature, we note that there are some aspects that with these thresholds or the methodologies that are used in order to evaluate the economic aspects of digital technologies are insufficient. So we need much more specific technologies to evaluate the economic framework and the benefit of activities and cost effectiveness. Thank you. Lilia, do you have a question or a comment? If not, that's fine.
Not too much, but there was work that was done on 7 different medical specialties where we wanted to evaluate the benefits and the challenges of not necessarily tele-rehabilitation, but surveillance, distance procedures, and I'm happy to link it in the chat, but the work is still very much exploratory and we haven't been able to assess any of these technologies yet.
Thank you very much. If you could please, it would be great if you can include in the chat any additional information. Bien, Passo ao espanhol de nuevo para decir
Now
que
I move to Spanish once again, and we will conclude. We've had more than 300 participants. Some have had to leave, but we still have online more than 250 participants. So we see that there's a clear interest in the subject matter. So thank you for your participation. And one final minute for your comments, Lilia, and then I will move on to our Spanish colleagues.
I'd like to thank everyone here, and it's obviously a very collaborative work. So the important thing is that we know where the work is heading, and we continue to strive together. I'm convinced that all of our healthcare system really all want the same thing: better care for the population. So thank you for this opportunity.
Thank you. Thank you very much, Lydia, for your participation. And we always count on the collaboration from Inés. We have several webinars with participation from Inés. We really appreciate a very active member of RedETSA. Thank you so much. Bien. Y pasar entonces a... Y también
and we will now move. And our first joint webinar with RedETSA and RedES means that I would also like to hear final words from Rosa Maria, who has shown us what the Spanish network is doing. And this way we will conclude. Rosa Maria, you have the floor. Thank you very much, Alexandre, and thank you to the entire team organizing this webinar. And I would also like to invite everyone to come to our website. And we hope that with Brisa, we will also be able to share our reports and our methodological frameworks. And we're also working on AI, and we're working with different European agencies. But if you have any questions, if you want to share your experiences, we would like to hear from you. Thank you.
Muchísimas gracias, Rosa María, también Carolina, Juan, Lilia, por este excelente.
Thank you very much, everyone. Caroline, Lilia, Juan, thank you very much for your participation. I thank all of the colleagues' participation as well, within and outside of the network. Those who have been a part of this or have just joined it, thank you very much. It was a pleasure having you here. Malaine, let's have Malaine turn on her camera. She's the one responsible for this webinar. Thank you very much for giving me the floor. Yes, it's a true pleasure for me to have taken part in this and to organize these webinars for the network and for anyone working in health technologies in our region, and working with other institutions and other networks from other regions throughout the world. We don't yet have a date for the next webinar. We know that there are going to be some that are quite interesting, worthwhile, but the global conference, we're going to be resuming in August, October, September, the first Friday of every month in the morning. We will be holding one of these webinars. We'll be in touch with you through the different networks on the listserv that we have, and a link if you want to receive information from RedETSA if you're not yet members. Thank you very much. Thank you, Malaine. I thank the whole team that has supported us. I thank Abraham for his support. I thank the interpreters for their excellent work. And Marcelo, I think he's already disconnected. I thank him for his for kicking out this webinar. So all those colleagues that haven't been able to take part in this, we will have a recording of this webinar available. Feel free to spread it around. Let me know if the information I provided, Malane, is correct. So in the upcoming days, it always takes a couple of days to put the videos and presentations up. So it's going to be available in the next couple of days. Spread the word. Now, the members of RedETSA will be holding a virtual meeting soon, as you know. We'll be sending you the details about that. And anyone who's going to take part in this global encounter of HTA, I thank you for taking part. Have a great weekend with your families. And with this, we conclude. Thank you very much. We'll be in touch.